Welcome everyone to hashtag CRArthritis. I'm Kelly Lenvoy, and it's my pleasure today to be speaking with Dr. Denis Poddubnyy. He's a professor of medicine at the University of Toronto and senior scientist at the Schroeder Arthritis Institute at UHN. His clinical and research work focuses on early diagnosis, treatment, and imaging in spondyloarthritis and psoriatic arthritis. He's leading projects aimed also at advancing precision medicine and improving patient outcomes in inflammatory arthritis. Dr. Poddubnyy, welcome to our show.
Thank you very much. It's a great pleasure and honor to be today with you.
We're going to focus on a presentation that you're making at the CRA's annual meeting, and that's tough to treat, rethinking strategy in tough to treat rheumatoid arthritis. And before we dive into that presentation, I want to welcome you to the show. We haven't met before, but I have heard a lot about you, and I just thought it'd be helpful and interesting for our audience just to learn about your journey that you made from Germany to Canada over the past, I guess, 2 or 3 years ago, and what that experience has been like, and maybe talk a little bit about maybe some of the differences you found between the two systems and maybe the lived experience for people with arthritis in dealing with that healthcare system in the two countries.
Thank you very much, Kelly, for asking. Indeed, I joined Toronto team here at the UHN in July 2024. Before I was working as a professor and head of rheumatology department at the Charité University Hospital for about 8 years, focusing on spondyloarthritis and related conditions. And when I received this offer to join the team, I came to Toronto to visit. I saw a really great environment, great people here, and I still think that Canada, and in this case Toronto specifically, is a great place to work and to live. I learned a lot over the past 2 years. It was really amazing experience to start working here. The good thing is the medicine is the same. So medical knowledge, what I was applying, gaining in Berlin, what was applicable also in the Canadian system. There are some differences, of course. And again, a good thing about Canadian system is that everybody who needs an appropriate treatment is getting this treatment. There is some bureaucracy, and this bureaucracy can be more complicated than in some European countries. There are, however, some measures implemented to make this transition and initiation of advanced therapy, such as biologics, easier on various levels. And what I found particularly interesting and positive about Canadian system is a strong patient support program or strong patient support programs supporting use, initiation, and continuation of various medications. So those programs, they literally do not exist in Europe. Yeah, so it was overall very interesting journey. Another aspect is very close work with patients as advisors. So in our program at the UHN, we have a patient advisory committee who help us to shape our research to make it relevant also for people living with arthritis. And we organize every year, already for many years, it's a long tradition here, patient-centered symposium. And since last year, we started to do this symposium not only for people living in Toronto or Greater Toronto area, but for the whole Canada. So if you are interested, stay tuned. We'll be doing this fall again.
Excellent. Well, thank you for that perspective. I certainly when we've attended the EULAR meetings and talked to our patient organizations and colleagues that are attending that conference from all parts of Europe and around the world, certainly what strikes us is that the level of patient participation, whether in research or education and advocacy, generally, I think, is a little more advanced in Canada than a lot of the other countries and the people that we talk to. So it's something I think for our audience to keep in mind that we really benefit from that patient involvement at those different levels of treatment and care. And we're going to talk today. I mentioned in your bio that your sort of specialty area is spondyloarthritis and psoriatic arthritis, where you've done a lot of work. But the presentation that you're making at the CRA is around RA and the tough to treat rethinking strategy and tough to treat RA. For our audience, I would like to start maybe with some definitions, and that is, what does tough to treat actually mean? And why do some people respond and others don't respond as expected to current therapies?
To be honest, this presentation will be done in tandem with another rheumatologist from Canada, from Quebec, Dr. Louis Besset.
Hmm.
And Louis will be talking about tough to treat rheumatoid arthritis, and I will be complementing this with tough to treat spondyloarthritis and psoriatic arthritis.
Oh, okay.
So it is one session, and we will be talking about the same thing. So I can answer your question
Sure.
in relation to any rheumatic condition. So tough to treat is an umbrella term to characterize all the possible situations we are facing in clinical practice where we see a person with a musculoskeletal condition, in most cases with inflammatory musculoskeletal disease, where for whatever reason we cannot achieve the desirable outcome. In most of those situations is a complete control of disease, meaning control of inflammation and control of symptoms. So anytime we are not achieving the desired outcome desired by the patient or by physician, where we can speak about tough to treat disease.
So when someone's inflammatory arthritis, psoriatic, spondyloarthritis, rheumatoid arthritis is difficult to treat, how does that change the strategy for care? And what should patients know about the different options or approaches that their healthcare team might consider?
This is a very good and very important question because this is currently a rapidly evolving field. If you look at the treatment guidelines for any rheumatic condition, you will see that those guidelines, they are pretty linear and straightforward. They define a certain treatment target, and every time we do not achieve the treatment target, we need to change or to escalate the treatment. And in most of the cases, the assumption which is integrated in these treatment recommendations, and it doesn't matter whether we're talking about RA, SPA, or PSA, the assumption is that the disease activity is responsible for patient symptoms. And we are coming now to an understanding that the treatment options we have as of today, they are so efficacious that we are able to control inflammatory activity in most of the cases, meaning that in the majority of situations where we apply effective anti-inflammatory treatment and we see that symptoms are still persisting, we need to think about other potential explanations for those symptoms. And this is something that requires some paradigm shift in minds, in people making recommendations, but also in people following those recommendations, that we need to look also a little bit over the border and see what can be responsible for persistent problems.
So I think what you're describing is a concept that our audience may have great familiarity with or have encountered in their research or discussions with their healthcare team. And I'm thinking of two terms that maybe you could help define for our audience because I think they hear about them or they read about them, but maybe not exactly clear what they mean. And that is treat to target and also precision medicine. Maybe just for the benefit of our audience, could you help define in their minds what these two concepts are?
Absolutely, and they are very helpful in this concept. So, treat to target is is a concept. So, it's not a cooking book. It's not a clear guideline for rheumatologists or other physicians. It is a concept saying that in every inflammatory disease, before we start treating, we need to define a treatment target, and then in the following months, we need to follow the strategy most likely resulting into achieving of this target. And to speak common language, the same language between different physicians for every disease, such a target is defined, mainly based on particular indices or patient-reported outcomes. But conceptually, across all the diseases, we're aiming for controlling inflammation and controlling symptoms. And all the targets, all those composite outcome measures, they include patient-reported outcomes, for example, pain, stiffness, global assessment of disease activity, and a measure of inflammation, sometimes systemic inflammation, sometimes local inflammation in terms of swollen joints. So the target is always to be inflammation and symptom free. And precision medicine is a concept saying that we do not have something that would fit to everybody. So that we need to differentiate between various clinical situation scenarios to find proper treatment, right treatment for the right patient. So this is precision medicine. Before we were using term individualized approach, and it is also an evolving concept, very much evolving concept, because this concept can be applied at different stages during the disease or patient journey. Many years ago, we were thinking that it would be very helpful to know straight at the beginning which drug would be right for this particular patient. And it is still somehow around this idea, and this is a proper idea, but the overlap in the efficacy between various treatment options is so big that in my eyes, in most of the situation, unless there are specific features preventing me from giving one or another drug class, we can go with whatever treatment option is currently available or deemed appropriate. And then if we do not achieve our treatment target in 3 to 6 months, we need to think about individualization of the approach, trying to identify what are exactly the reasons preventing us from achieving this target. So you see, there are multiple points over potentially over many years of the management of inflammatory disease, where those decisions needs to be taken, and we're looking right now at identifying predictors or factors which would help us to modify our management strategy in an evidence-based way.
For our audience, I'm going to remind them that there are going to be some links at the end of this presentation where they can further learn and explore around some of these topics. So please look out for that. Take advantage of that if you want to learn more. Thank you very much for sharing that. I think that was really, really helpful for our audience. I wanted to just to change tack a little bit here. You are also, as mentioned in your bio, one of the leaders in Canada who's using artificial intelligence (AI) um, to analyze, for example, MRIs and X-rays for diseases like spondyloarthritis. We ACE conducted a national survey last year on people living with arthritis and their understanding and use of AI in their treatment of care. And I think it would be interesting for our audience to learn maybe a little bit more um, from you about how AI is helping doctors and specialists detect or understand inflammatory arthritis earlier or more accurately.
Thank you very much for this question. Indeed, AI is now everywhere, and we're talking about proper AI applications. So I believe that AI in general can be a very helpful tool. I believe everybody in our today's audience is using somehow AI, asking from time to time ChatGPT or another tool, and this is what doctors are also doing. The only problem with all those tools is they cannot substitute an evaluation by a specialist, because interpretation of the clinical picture, interpretation of what we're seeing is what currently available large language models are not able to do. They work with facts. So if you feed the model with information, I have arthritis, the model will provide an answer how to deal with this in more or less specific way. But the question is always, what type of arthritis is this? Is it an inflammatory arthritis, or is it osteoarthritis, and so on and so forth. And another shortcoming of currently available AI tools, they are pretty generic, and they are not very specialized. So their training is based on the whole amount of information available currently in the internet at the time point of data cut, but internet doesn't contain sufficient amount of highly specialized, high quality information, for example, on the images. And this is where we realize that we need to work on specific tools. In the field of inflammatory conditions involving axial skeleton, so spine and sacroiliac joints, so-called axial spondyloarthritis, or older term ankylosing spondylitis, we have nowadays a big issue of over or misinterpretation of imaging findings. And this is related to a very steep learning curve we experienced in the last years on how to differentiate mechanical, non-specific changes on MRI from those which are attributable to inflammatory immune-mediated disease. And that was a motivating factor to start working on a tool that would be able to help physicians, rheumatologists or radiologists, to get an idea whether findings on the image are compatible with inflammatory disease, or rather with mechanical degenerative problem. And this is where I believe we're heading now to, and we published already several initial, quite promising results. So properly trained AI tool is able to detect structural changes compatible with spondyloarthritis and also active inflammatory changes. Another area of application of AI tools is an analysis of large data sets. Yeah? For instance, thousands and thousands of um, images where any human reader would need years of work, while properly trained AI tool would be able to analyze this rather quickly in a few seconds to minutes. And this is also quite a successful aspect of this work. We just recently were able to analyze 13,000 of MRIs obtained from a large population-based study to demonstrate how frequent non-specific changes on MRIs are. So this work will be published very soon in Lancet Rheumatology.
Fantastic. I will provide a link to some of the work that you're doing in this field, and I also will provide a link to our survey in case people haven't seen that. I'm looking forward to being able to follow up with you on this topic because we are starting to consider the development of some programming around AI, and I'm really looking forward for you to be able to be one of our advisors on that. I think we'd like to wrap up right now, Dr. Poddubnyy, by maybe just a final word around patients who find themselves in a situation where they're dealing with a tough to treat type of inflammatory arthritis, that their treatment maybe isn't working. What advice do you have for these people in terms of steps that they can take to have, a better, more informed conversation, let's say, with their healthcare provider, and to be part of that decision-making process and trying to receive better care?
Yeah, absolutely. And I think this question is really crucial, and it requires understanding at both sides. First of all, you need to think about how your disease, how your condition change over the course of treatment. Are the symptoms are the same, or are they different? What improved? What stayed? And it is also very important to try to understand if the inflammation in the body, reflected by various parameters, but first of all by objective swelling of the joints or other parts of the body, by markers which your doctor measures in the blood, whether this component has improved or not. And then there are several modifiable factors, potentially modifiable factors, which can contribute to the perception of pain in the body, although the inflammation is very well controlled. And I'm talking about such factors like sleep, so poor sleep, problems with sleeping may really sensitize structures in the brain to perceive signals your body is sending as painful signals. So this is first aspect. Second aspect is overweight and obesity. There is a very strong link between high body mass index and higher likelihood of having chronic pain syndrome, so pain not related to inflammation, such as fibromyalgia, and some socio-psychological factors such as presence of anxiety, depression, that may also be strong contributing factors to the perception of having pain, although inflammation is very well controlled. So these factors are normally those factors you need to think about, and you need to talk about with your rheumatologist, and try to figure out together with your specialist what is more prevailing in the current situation. Is it really uncontrolled inflammatory activity? In this case, the rheumatologist would be able to help to modify the treatment, to change the treatment if needed, or these are other factors you need to work on together with rheumatologists or other specialists.
Dr. Poddubnyy, thank you so much for joining us today. Your presentation and your research really provides, I think, a lot of optimism and hope for patients who may be having real struggles dealing with their inflammatory arthritis. So we're so happy that you've been able to join us and to share this work with our audience. Thank you again.
Thank you very much for having me. It's my great pleasure, and I'm looking forward for future events.
And good luck with your presentation. And thanks to our audience for joining us. Bye for now.